as well. I'm never going to get used to that. All right, I see some people joining us. Welcome. We're just going to wait a little bit yet to let people join before we start.
I'm doing this again while I'm trying to figure it out.
That's okay. I have some housekeeping stuff anyway if you need if you need a minute.
Yeah, I'm fussing around. I know it's in here somewhere.
All right. Well, like I said, I have some housekeeping stuff, so I think we'll get started. But welcome everybody to this week's virtual meetup hosted by the Epilepsy Foundation of Wisconsin. This evening, we're going to be focusing on epilepsy in school-aged children, as well as talking a little bit about IEPs and 504 plans. So some of the housekeeping items. We are recording this call, just so you know. If after this, when this call is done, if you would like the recording, please reach out to me. I can type my email in the chat section. As I mentioned, if you've listened to the last couple of weeks, we're currently working on our website, and we usually put the recordings there, but while it's being worked on, the latest ones have not been posted yet. So if you would like it, just please let me know. If you're an attendee on this call tonight, you are muted and your videos are also off, but we do encourage you to ask questions, and you can do so by using the Q&A or the chat section on your screen. Either way is just fine. John and myself will be monitoring those for Kristen. And then as far as questions, if your question doesn't get answered, if we run out of time, or if you think of something after the fact, you can use our Connect email, which I saw that John just typed it in the chat section for everybody. So feel free to utilize that email if you think of something after the call is done this evening. With that said, we're going to do introductions. So hello, everybody again. My name is Alicia Thompson. I'm the program manager for the foundation. We also have John with us tonight.
Good evening, everybody. John Marisola. I work with Alicia at the foundation. I mostly work with communications and client support services.
Wonderful. Thanks, John. And our speaker this evening is Kristen Seaborg. Kristen is a pediatric neurologist and sleep medicine specialist at the American Family Children's Hospital in Madison. So welcome, Kristen. I'm going to turn it right over to you.
All right, great. Thank you. Thanks. It's nice to be here. Forgive me if you hear dogs barking. My dogs have figured out how to come up to my office window and whine.
That's okay.
Just they're right out there right now. Okay, so I'm a pediatric neurologist at the Children's Hospital, have kids of my own, former pediatrician as well. So I've talked to a lot of families over the years about how to navigate the school system, especially if you have a kid who has any special needs, whether it's epilepsy or anything else. So today I thought we could talk about epilepsy in school-age children and then kind of expand that discussion into how you can help them succeed in school, whether they need an IEP or a 504 plan, and how we can achieve those goals. So first, I wanted to just go through some of the things, and I've talked about this before in this setting, so forgive me if you're hearing some of this again. But all of us know epilepsy is more than seizures, tends to affect a lot of our lives and a lot of the lives of children that we're caring for. And as I'm sure you all know, children with epilepsy are at increased risk of a variety of other kind of different conditions that can impact their ability to function in school and at home. So kids with epilepsy are at increased risk of ADD or ADHD. They're at increased risk in some cases with cognitive disability, mood disorders, trouble with sleep. And of course, medication side effects, the medications we use to treat epilepsy can cause difficulties with learning and difficulties with maintaining kind of normal focus and function in the school environment. So briefly going through each one of these and then how this will transfer into kind of 504 plans or helping them succeed in school. ADD and ADHD has been shown to be present at higher incidence in children with epilepsy. In fact, kids and adults with epilepsy have 3 times the risk of having ADD or ADHD compared to children without epilepsy or other conditions. And if you have a child with ADD or ADHD, you might know that if it's undiagnosed or untreated, it can actually have a profound impact on their life, not only in school, but in other settings where their brains don't work in the way that some other kids do, and they have trouble with attention and focus, not trouble with learning or not trouble with cognition, but trouble maintaining that attention and focus. Studies have actually shown that if undiagnosed and not treated, ADD or ADHD can have actually more negative effects on the quality of life of a child with untreated ADHD than epilepsy itself. Some of the classic kind of symptoms of ADD or ADHD are symptoms like inattention, distractibility. Some kids with ADHD are described as being always on a go or driven by a motor. And sometimes some older kids who are presenting this way might have unfinished projects. They might be the kids that do something for a while and then they forget to turn in their assignments. And depending on the type of symptomatology, these kids might present early if they're the hyperactive type, or even maybe a little bit later if they're the distracted type, and just the kids who are kind of daydreamers in school and having trouble paying attention. One thing that's important as a provider, as a parent of a kid with ADD or ADHD, is that in order to achieve a diagnosis of these disorders, kids have to have symptoms in 2 of 3 settings. So when I was a primary care pediatrician doing ADHD evaluations, sometimes I'd have kids that would come to me and they're like, oh, they're always hyperactive at school, but they come home and they can focus and they go to, they sit in the doctor's office quietly, and those kids don't have ADD or ADHD. It has to be in 2 out of 3 settings, and this evaluation has to be done across the board before we consider treatment or further evaluation for these disorders. ADD or ADHD can be diagnosed by your PCP, can be diagnosed by a neuropsychologist, especially for the kids that are in epilepsy clinic, also seeing a neuropsychologist. Sometimes psychologists or psychiatrists, and sometimes neurologists will diagnose these disorders. Kids with mild symptoms actually can be treated with behavioral interventions, helping them to focus on the task at hand while trying to ignore the extraneous stimuli. And kids with less or more than mild symptoms often do require or benefit from treatment with stimulant or non-stimulant medications. This will become important again to think about when we talk about 504 plans and ways to kind of help these kids perform their best at school and succeed in a school environment. Kids with epilepsy can be at increased risk of cognitive disability or learning disabilities as well. This can happen in kids with epilepsy for a variety of different reasons. Sometimes the genetics that led to a person having seizures actually can be associated with cognitive disability as well. Different types of seizures, so kids that have generalized seizures or staring spells or generalized seizures tend to have more cognitive disability than the kids that have more focal seizures don't always struggle to learn as much. A lot of the anti-seizure medications can impact our ability to focus and concentrate, and then can later manifest as trouble with learning. And then there are some genetic differences or genetic variants that are associated with seizure types, but also come along with some cognitive disabilities. The duration of epilepsy can also make it hard to learn for some kids. Kids that are diagnosed later in life and have their early part of school without seizures, without seizure medication, sometimes don't have as much trouble learning as the kids that have early onset seizures that persist and that are difficult to control. And those kids tend to have a little bit more trouble with learning. Recently, a study was done of 750 children with epilepsy, and the global cognitive function was within the normal range for 75% of these patients. This is something that's really important to note, especially with the stigma that often is associated with epilepsy. Epilepsy does not equate learning disability or cognitive disability. In fact, most of the time it does not come associated with those things. So while it's important to remember that these children are at increased risk of difficulty with learning, it's also important to remember that one does not equal the other. Like I mentioned before, the age at onset of epilepsy can impact a child's ability to learn. History of any structural brain abnormalities that's associated with epilepsy can make that child more at risk for cognitive disability. And the types and the kind of number of anti-seizure medications needed sometimes is correlated with cognitive function. So the more medications a child needs sometimes can be associated with more difficulty with learning. We also know that chronic seizures, especially early in life, can affect brain development, can affect ability to learn, and can affect overall cognitive function in the long term, especially early difficult to control seizures in children. In addition to kind of the cognitive disability or the trouble with learning that some children can have kind of not independent, but along with their epilepsy, over the years of chronic uncontrolled seizures, this has been associated with some cognitive changes too, which is important to remember as school-age children grow older and as their academics become harder. Again, I've mentioned this before, but patients with primary generalized seizures are much less likely to have cognitive changes than patients with focal seizures. So that's actually not the grand mal seizures, but just primary generalized. So the kids with staring spells over the long term do tend to do okay. Focal seizures can lead to disruption of the tasks that are associated with the area of the brain that's affected by seizures. So if children have a focal seizure that starts in the brain, the portion of the brain that controls language, this might come out as difficulty speaking or understanding language, especially if the seizures are happening recurrently from one area. Seizures that start in the place of the brain where memory is stored, the temporal lobes or the hippocampi, sometimes have difficulty with rapid recruitment of memory, with quick learning, and sometimes with some of those longer memory tasks. And then at the parts of the brain that control executive function, which is really the frontal lobe, and sometimes the temporal lobe, can also, kids that are having seizures originating from this area can have problems with organizing tasks, with multitasking, and sometimes with executive function. So organizing, tasking, moving on from one task to another. Also important to remember, kids with epilepsy are treated with anti-epileptic medications that are designed to kind of control or quiet the abnormal electrical activity in the brain. Anytime we're trying to kind of decrease neurotransmitters or control electrical activity in the brain, this can come with some side effects, specifically with sedation a lot of the time, and sometimes with impairment in cognitive function. You guys might be familiar with this if your children are on things like Topamax, Onfi, clonazepam, especially acutely. Some of those can have some effects that affect their school day and their ability to learn when those medications are active. Some of the older medications like phenytoin and valproic acid and phenobarbital, used over years early in life, have been associated with cognitive changes in the long term. And then I mentioned Topamax, also zonisamide. Those two of the newer medications have been associated with difficulty, especially with rapid memory recall and learning tasks. These are important things to remember if your kids are on these medications and if they're struggling in the school environment. This is just another reminder of some of the more recently introduced medications that can be associated with sedation that can be interpreted as a cognitive side effect. So clobazam or Omfi, the Epidiolex or cannabinoids, and clonazepam is a benzodiazepine. All of these cause sedation. All of these cause decreased excitability in the brain, and then associated sedation that can be interpreted as difficulty with learning. Finally, mood disorders. Probably a lot of you know that there's a higher association with people who live with epilepsy and mood disorders as well. And sometimes, especially in younger children or in the school setting, the manifestations of mood disorders like depression can be misinterpreted or interpreted as difficulty with learning. So there's 2 times the incidence of depression in patients with epilepsy compared to the patients who are not living with seizures. You've probably heard before, suicidality is also an increased risk for patients with epilepsy. And something that is always, I think, interesting to remember is that depression and epilepsy are linked. Poorly treated depression can lead to increased incidence of seizures, and then increased incidence of seizures can lead to worsening of depression. So getting on top of both of these and being aware that both of them tend to coexist with each other is very important for the success of our children, or all of us living with epilepsy. And then, like I mentioned before, patients who have mood disorder may look like they're struggling to learn. Their symptoms that manifest in the classroom might be that they're tired, they're having trouble concentrating, they're having trouble focusing. So when you see a kid with a new onset of these symptoms, or if your child has epilepsy and you're starting to see more changes in the school environment, it's important to bring that up to your provider and to consider if there's another cause that's leading to these symptoms. So that was just a quick run through of some of the other things that might come along with a seizure disorder or with epilepsy that might lead to difficulty in the classroom. But what we're really here to talk about today are things like IEPs and 504 plans. Briefly, I just wanted to go through the difference between an IEP and a 504 before we talk about the nitty gritty of what these plans might involve and how you might get one for your child. So first of all, individualized education plans, or IEPs. This was taken, the verbiage here was taken directly from the Department of Public Instruction of Wisconsin. Here's the website, dpi.wi.gov. So an IEP is a written statement for a student with a disability that's developed, reviewed, and then generated by a team of people. The team of people not only includes educators, but also includes the student's family, and often includes some input from their physician as well. And this outlines the educational plan for the student, and is changed and updated and kind of reevaluated on a 1 to 3 year basis as the student moves throughout the school environment. The IEP was an outcome of the Individuals with Disabilities Education Act, or IDEA for short. In Wisconsin, what this means is that all children that have disabilities that are defined by this act, that are between the ages of 3 and 21, are entitled to enrollment in public schools, are entitled to an IEP to meet their special education needs, and entitled to ways to help them learn, not always in the mainstream classroom environment, but sometimes in a school environment that's within the school, but is specifically tailored to these children. To qualify for protection under the Individuals with Disabilities Act, a child must have a disability that adversely affects his or her ability to learn, and also affects their ability to be able to succeed in a typical classroom. And so these children are identified as needing special education and special education related services. Just some definitions, because it was hard for me as a pediatrician to kind of understand specifically what this meant. So disability in the context of special education means the existence of a problem of physical, mental, or emotional impairment that requires need for special education services. This can be defined by a healthcare provider, or the healthcare provider can help identify these problems, but the healthcare provider cannot really actually prescribe disability services, and they cannot prescribe an IEP or mandate that a child has an IEP made for them. So it's just important to remember, while your physician is important in helping achieve the diagnoses, and often their documentation is helpful to help you move forward in the school setting, ultimately the school personnel and the people working within the schools are the ones who will generate this IEP and help the child succeed in the school environment. Oops, excuse me, wrong arrow. We'll get into this nitty gritty in a few minutes, a little bit more, but IEP versus 504, it actually wasn't until I really delved into figuring out the differences that I really understood what the difference was. So the IEP has been around for a longer time. This was generated as a result of the Special Education, or the Individuals with Disabilities Act, whereas the 504 plan, I'll talk about in a little bit, was actually generated from this Rehabilitation Act of 1973. It's actually Section 504 of the Rehabilitation Act of 1973. The IEP and the 504 plans are mandated and governed by two different departments. The IEP is governed by the Department of Education. 504 is governed and kind of mandated by the Office of Civil Rights within the US government. Included in an IEP are special education services, accommodations, and related services. Often an IEP is administered to a child who does not learn in the same classroom as other children, or who learns in modified classrooms that are within the are within the main classroom, but might be slightly different. Whereas children who have a 504 plan are learning in the same environment as other children who do not have a 504 plan, but they have modifications and accommodations for them in that classroom. IEP educationally is used through 12th grade or through age 21, does not transfer to college. And the 504 actually can transfer with these children or with these young adults through the college age, and they can continue to receive the same accommodations through the college years. So what are the similarities between these two things? Both of these are documents that outline accommodations for that student. Both of these are mandated under federal law. The law is a little bit different. It's the IDEA Act for the IEP and the Rehabilitation Act of 1973 for the 504, but they are both federally mandated. Both of these documents are provided to all the educational service providers who are responsible for the students. So they're not like existing in one little microcosm of their educational environment, but they are kind of uniformly addressed and administered throughout that child's learning environment. And federal and state guidelines apply to both the IEP and the 504 plan. Where they're different is that an IEP can be developed for all students who require special education services, but a 504 accommodates students who can learn within the general environment with some certain modifications. 504 plans similarly can be used on an as-needed basis. So this would even include like physical accommodations for a student who has a temporary injury. they have a broken leg that's going to take 9 to 12 months to heal, the 504 could incorporate how they're going to transport throughout the school, how their gym class will be different, things like that. Whereas the IEP is a longer term document that will follow the child through most of their school years and change with them as they change. IEPs constitute a fully active special education plan. And while everything that's included in a 504 can be included in an IEP, everything that's in an IEP is not necessarily able to be included in a 504. So an IEP is much more comprehensive than a 504 plan, and it's much longer lasting and more durable over years. Forgive me for the small print on this slide. This is just a little bit more about what the 504 plan is and what it entails. So I mentioned it's from the Rehab Act of 1973. And the act itself forbids federal agencies who were receiving federal funding. It forbid them from discriminating against individuals with disabilities. And what it specifically said was that for individuals with disabilities or limitations on their daily activities, public schools needed to make accommodations for all of these children. From this section of the Rehab Act, that's where we get the term 504 plan that you'll hear often thrown around in the schools. This is a federal mandate that all states must comply. So, and it's also across the country. So while a 504 plan in Wisconsin shouldn't be different from a 504 plan in Florida, shouldn't be different from a 504 plan anywhere else in the country. So these apply to all states and they should be the same. And what 504 plans do is they outline the strategies used to help children with disabilities, and they help them achieve the same education as their classmates. And they're also generated and written by individuals with connections to the students. So they're not like generated somewhere outside of the classroom or for people who've never met your child, if this applies to your child. So in the 504 plan generation or meeting, there's often special education teachers, there's administrators from the school, there are the teachers from the school, there are parents. Sometimes there are other like occupational therapists, physical therapists, people who have worked with the student and know the student well and have the best interests of the student in mind. In order to qualify for a 504 plan, this is kind of a broad qualification that sometimes is narrowed down a little bit further by the school district. So first of all, a student's disability must impair his or her ability to participate in the daily activities of the school day. And usually what happens is when the children is identified as potentially needing a 504 plan, the school officials conduct an evaluation and then they determine if the children's disability meets the criteria outlined in section 504. And then they also require periodic reassessments to measure the student's progress and then adjust as needed. And then eventually, perhaps, if it's a short-term disability, determine if the children or the child no longer needs the accommodations provided in the 504 plan. Important to remember, compliance with section 504 is not optional. So some parents have come back to me as a primary care pediatrician in my old life, and they'd say, well, the school says that they don't do 504 plans. That's not the case. That's just not an option in a public school in Wisconsin. Private schools may have different rules, but big asterisk, well, anybody can refer a child for evaluation under section 504. The school district also must have a reason to believe that that child needs a 504 plan. So ultimately what this means is a parent can't, it's not enough for a parent to come to the school and say, my child needs a 504 plan. The school needs to agree with you and feel like that's necessary. In some cases, the school will ask for some formal request or documentation. And sometimes if your child's physician or specialty provider agrees that they may qualify or may benefit from a 504, some additional documentation from your physician might be helpful to achieve that 504 or to help the school understand the position that you're coming from so they agree that your child might need some 504 accommodations. Just some further definitions so you understand what the 504 plan entails and who 504 plans tend to cover. So 504 is designed for an individual with a disability, and this is defined as in this section of the Rehabilitation Act, any person who has a mental or physical impairment that limits one or more life activity. So personally, I think these terms are fairly vague. So an impairment, as the way it's written in the law, is any disability, any long-term illness, or any various disorder that substantially reduces or lessens their access to learning in the educational setting. And then it limits a major life activity. What does that mean? A major life activity can include self-care. It can include manual tasks like walking, seeing, speech and talking, even sitting and thinking, learning, breathing, concentrating, interacting with others, or working. This was expanded further with the expansion of the American with Disabilities Act in 2009. Major life activities then also included things like reading, concentrating, lifting, or bending. So this kind of stuff, back to the reading and concentrating, is how we come back to the beginning of what I started talking about. So children with ADD or ADHD, children with cognitive disability, children that are struggling with medication side effects because they're having trouble with attention and focus, may definitely kind of fall under that umbrella of children that would benefit from a 504. Some kind of online forums or things that are written about 504 on the internet. Some parents had expressed some concern about, well, will my child be evaluated for a 504 or actually placed under a 504 plan without me being aware of this? The federal law actually requires that parents must be given notice when their child is evaluated for a 504 plan. And then, as we've mentioned, every child's needs are determined individually. There is no like uniform 504 plan that applies to every child in the school that needs accommodations to learn. So each child, if they qualify for a 504, will have an individualized meeting that will determine what is appropriate for that child to succeed in the classroom, and so they can compete with their children or with their fellow peers who do not have a disability. And then if their 504 applies to a illness or a disability or a condition that exists over years, they do need to be reevaluated every 3 years at least, or when there's a significant change in placement. So if there's a move from elementary to middle school to high school to college, every time they will need a reevaluation of their 504, a reevaluation of their accommodations, and kind of reconsideration if those accommodations are all appropriate. So what does a 504 entail? I mentioned it's different for everybody, but it's helping your child with a disability achieve success in learning in the classroom, in the same classroom with children who are not affected with similar disabilities are learning as well. So certain accommodations, this is a small list that was taken from the Children's Hospital of Wisconsin, but there's a variety of lists you can find out there. But some things that may be included in the 504 are things like where they sit in the classroom, if they have extended tests or time on tests or extended time for assignments. Maybe they may have reduced homework, reduced classwork, so they can get what they need to get done in an efficient manner and learn from what they have instead of being overwhelmed by their tasks. May include some verbal or technology aids, modified textbooks. Some kids who qualify for a 504 do have some behavioral difficulties. So behavioral management and support and kind of uniform ways to respond to the behavior of this child in the classroom so that it may succeed in the classroom can be part of this plan. There might be adjusted class schedules, adjusted grading, verbal testing instead of written testing for children who have difficulty with reading or some sort of language disorder. These children, especially the ones, excuse me, who have some executive function problems, might have excused lateness. They might be able to miss more school. Children with epilepsy who need to miss some school because of recurrent seizures. This can be part of your 504 plan, so there are no repercussions coming back to the home or coming to the child. Also, these kids might have pre-approved nurses visits, especially if they need to receive medications while they're at school or if they just need a break while at school. This can be part of the 504. Occupation or physical therapy can also be part of the 504 and prescribed for your child's treatment plan in order for them to succeed in the school environment. So for children with epilepsy, there's some things to consider as we kind of engage in that 504 development process and kind of creating a plan that will help them be most successful in the classroom. There's a really, really good model for a 504 plan for a child with epilepsy on the Epilepsy Foundation website. Here's the website if you'd like to reach it. I'm not going to go through the whole plan because it's actually quite in depth, but they did talk about some core principles for children with epilepsy in the school environment who have a 504 plan. They say it's very important that any staff member who cares for the student during the day, during the school hours, understands what epilepsy is, understands what the typical healthcare needs are for a child with epilepsy. Any bus driver that transports that student also needs to be aware of what epilepsy is, how to respond to a seizure, and how to recognize a seizure. And also kind of in these plans, in the initial phases of planning, it's really important to identify the child's level of self-care and what they need in the school day, in the school environment. For instance, children that are on medications that need to be administered at school, they need to know how to get to the nurse's office if they're independent, or they need somebody available to help them get to the nurse's office for medication administration, and kind of discussing how that's going to work into their day. In addition, excuse me, for children with seizure rescue plans or who have seizure medications at school just in case they have a breakthrough seizure, the 504 should detail where the meds are, how to administer the med, and then it should detail responsible individuals who can administer those medications in the event that a child has a seizure at school. These individuals should not only be identified, but should have specific training on the medication that needs to be administered if they have a seizure, and also kind of making sure that these people know how to recognize a seizure as well. Some other things to consider for children with epilepsy, doesn't apply to all children with epilepsy, but should be on a school's radar if we're evaluating a child with epilepsy. So kids on the ketogenic diet, as you probably know, have a really, really restricted diet that kind of impacts a lot of their life. So 504 for kids with the ketogenic diet should not only train the staff on how to avoid, increasing their carbohydrate count during the day, or some breakthrough too much carbohydrates or too much protein or something that would actually break the ratios. But the classmates of these patients, it should be identified in the 504 plan, should be given information about the ketogenic diet, and should understand that that child should not have any other, food in the school environment from a classmate. Similarly, birthday parties, school treat celebrations should be kind of detailed and lined out that that child should not be exposed to any food other than the food that's in their dietary plan. Children with vagus nerve stimulator, we talked about training school personnel and identifying school personnel who can administer rescue medications. If a child has a VNS, there also should be school staff who are identified as those who are trained how to swipe a magnet, those who know how the magnet works or how the vagal nerve stimulator works. And then they should also be trained to recognize a seizure and know how to respond to that appropriately. In that list of things that are available in the 504 plan, where the child keeps their magnet is probably another good thing to just very specifically lay out in detail, so there's no questions when the time comes. So a lot of parents might be wondering, how can you request an IEP or a 504 for their child, especially if they feel like their child is struggling in school and they're struggling to get through to their school, or to have them understand that, epilepsy is more than seizures, my child is struggling. So I mentioned before, in order to qualify for a 504 plan, unfortunately, just calling the school as a parent and saying, I want my child to be evaluated for 504 plan isn't always enough. So it's good to not only request that, but there are actually some really formal templates of 504 request letters that are available on the internet. Often these letters are asked for a physician's signature, or at least specific diagnoses laid out there. So it becomes a little bit more kind of formal in an environment where the school is not able to just say, we don't do that, because this is part of their mandated need to meet the educational needs of each child. So as a parent, make sure that you're documenting their specific diagnoses. If their diagnosis is just epilepsy, that's one thing. But if they're diagnosed with epilepsy and ADD or ADHD, or epilepsy and cognitive disability, or whatever else might come along, that's important to diagnose as well. If you are requesting a 504, it might be really useful to gather examples of your child's schoolwork, examples of your reports cards, or any of their evaluations. You can provide your school personnel with documentation of, here's where my child is at this moment, and here's how I'd like to move forward with him or her. It's also really helpful to know who your schools or who your district's 504 coordinator is, so you can communicate directly with that person. Especially in the middle of a pandemic when everybody's struggling. Just sending a letter to a teacher who may or may not have immediate contact with that coordinator may fall in the list of things that just doesn't happen today. Writing a formal request always helps, and there are a lot of samples on the internet. I literally just Googled a 504 request letter. And then, as in everything in life, follow up and advocate. If you write your letter, you make your request, and you don't hear anything for weeks to months, I don't ever think that's from a lack of, or a lack of attention or wanting to do ill will. It's probably because there are a million balls in the air, and the one that keeps bouncing is the one that sometimes, needs to have attention. So keep advocating for your child if you think like this is something that would benefit them, and keep bringing it up if you feel like it would be necessary. And then once you get through the initial steps, the 504 evaluation process, as I mentioned before, isn't just a microcosm of a couple people in the school. It will involve educators, administrators, and importantly, caretakers and parents. So be part of that process. Your input as a parent or as a patient is invaluable to kind of help everybody understand what that child needs. Briefly, who can help? So as a parent with a child who has epilepsy or who has any other kind of condition that can affect their performance in school, sometimes it can be overwhelming to figure out, all right, I'm one person, how can I help my kid succeed? There's a whole bunch of resources out there. Obviously, the Epilepsy Foundation is one. They specifically have stuff on their website about requesting 504s or IEPs and what that might entail. Specifically in Wisconsin, here in Wisconsin, I've used the Regional Centers for Children and Youth with Special Healthcare Needs a lot. They have several different offices throughout the state. They're based out of the Weissman Center, and they are tremendous advocates for really whatever resources your child needs, whether it's educational or PTOT in the home, that kind of stuff. There are some numbers here, but actually, if you just Google the Children and Youth with Healthcare Needs, Special Healthcare Needs website, they're a tremendous source. I would use them if you're needing help in the school environment or really anywhere else if your child does have special needs. And finally, the Wisconsin Department of Public Instruction, the website is dpi.wi.gov, I think. Actually has a whole page of links to resources for families to use if they are looking to get an IEP or a 504 plan for your child. So this is a good resource to go to as well, and kind of you can work from there. As a parent, if you're a parent or a caretaker of a child who has epilepsy, what else can you do? Take it back to the basics. Be aware of things that happen along with epilepsy. Even though your child might have seizures and epilepsy, often that's just the tip of the iceberg, right? There's a whole bunch of other stuff that can come along with that. So keep your eyes open and keep watching for whatever else might come your way. I probably can't say enough as a provider, advocate. Often when things fall through the cracks or get lost, it's never because of malintent or trying to make something fall. It's usually because there's a lot going on. As an advocate and a parent, keep bringing things up if you feel like your issues are not being addressed, and bring them to multiple different sources if you need to kind of move your child forward. And then just the simple things. If you're a parent of a kid living with epilepsy, make sure they get their meds and they don't miss their meds. They take them on time. Watch for breakthrough seizures. If they're having more seizures, go back to your neurology provider and talk about medication choices or doses. And inform your neurologist about any concerns. If your child was doing well in the school environment and now is struggling more, keep in mind they're at risk for mood disorder. Keep in mind what medications they're on, that those might affect their ability to learn. And just kind of keep the full picture and the full spectrum in the back of your mind, because often there's a lot else to consider just besides epilepsy. And I went fast, but I think that's all for today. What questions do you guys have?
First of all, let me say thank you, Dr. Seaborg. That was terrific. Very helpful. Seriously, we get a lot of questions about this, so thank you. Let's see what's come in here. You mentioned earlier that ADHD treatment can involve behavioral intervention at times. Is this the same thing as replacement behavior often taught with children on autism spectrum disorder?
A little bit different. So do you mean like for kids with autism spectrum disorder, they're often the applied behavioral analysis, so they're taught to recognize like emotions and how to respond to things in a different way. That's what I'm familiar with autism. The therapy I'm familiar with ADD and ADHD is actually, it's more on drowning out all the other stimuli. The way I was taught as a pediatrician to talk to families about ADD or ADHD was kids with ADD and ADHD would have made tremendous cavemen. Because back when we were prehistoric, you had to pay attention to the predator over there, the squirrel over there, and the person that was behind you trying to get to your feed. And now we have to sit in these rows in classrooms, and it's really hard for kids that have like that brain to focus on what's at hand. So the behavioral therapies for those kids is often how to teaching the child to focus on the stimulus in front of them and get rid of the extraneous stimuli. So that's a long answer to your question, which I think is they're different therapies, both focusing on different aspects.
Okay, all right. Alicia, what do you got next here?
Sure. So you mentioned that 504 plan can be extended into the college years, I believe. Can you kind of explain a little bit why is that exactly, or just explain a little bit? Yeah.
Well, sure. Why is that? I think it's part of actually the law, the Rehabilitation Act of 1973, that this should continue in all educational environments. So that's not, unfortunately, you can't bring a piece of paper to your child's college and be like, here, do this. Well, 504, or like I had mentioned, they tend to reevaluate at every change in setting. If your child is going to college and they've had a 504, I would actually call your colleges. Sometimes like there's an ADA office, the Americans with Disabilities, or some sort of office that accommodates kids with learning disabilities. And then just say, I've had a 504, here are my accommodations. How can we get him or her evaluated for accommodations in the college setting? And sometimes that's longer tests, note-taking help, and things like that, so they can succeed in college as well.
Great, thank you.
Let's see here. It's been said that an IEP can be much harder to get approved than a 504 plan. I can back that up from clients calling us with questions like that. Why is this so?
Sure. So the IEP is way more comprehensive, and an IEP, part of what it details is having a specific classroom environment, which used to mean always taking that child out of the classroom or creating a environment in the classroom for the child to succeed. So it's much more comprehensive. And also the child has to have a specific disability that is lifelong and not changing, where 504s can be transient and can change over time. I actually meant to give you a list, and I don't have it right now, of the disabilities that are met under the IEP plan, but it's more comprehensive disability that will live with the child forever. So the short answer to that question is because the IEP is a lot more comprehensive and requires a lot more accommodations for a child, where 504 can be simpler things. And functionally speaking, that's probably a lot easier for a school to do.
So just to follow up then, if a child and their family, if they're rejected for an IEP, 504 should definitely be step 2? Absolutely.
In fact, the Department of Public Instruction website said the 504 plan is often generated in response to rejection of the IEP. Okay. And 504s can be kind of made more and more robust. So it doesn't mean you've hit a dead end. It just means you kind of need to go down another road.
Okay, all right. Alicia?
Yes, let's see. Kristen, I think we just talked about this not that long ago, but maybe you could, we had a question come in. Who would the first line of contact be? I'm interested in IEP for my child. And I know you said somebody at the school, but if you could just say that again, that would be helpful.
Sure, so somebody at the school, but also, maybe and I would also obtain documentation from your physician, your primary care physician, from your neurologist. If your child meets criteria or has physical therapy, occupational therapy, speech therapy, I would have all of those documents with you, documenting their disability and documenting some of their needs, and then present that to the school so you don't get in a circular discussion with them.
Okay, so it's actually both. It's the school, but also the care provider too. Okay, great. Yeah. Thank you for explaining that again. I have another one here. So since a 504 plan has information on, when a seizure occurs, if there's rescue meds and et cetera, you listed some stuff. Do I still need to have a seizure action plan for my child?
Yes, because the seizure action plan should be part of the 504. So it should be, and it's not that they're separate documents that don't exist together. It would just be like a part of the 504. So definitely should be there. And you can have a seizure action plan without having a 504 if your child does not need any accommodations in the classroom.
Okay, thank you for explaining that. John,
Mhm.
anything else?
You had mentioned executive function at least twice. Can you describe what that is?
Sure. So the way we think of it, executive function is often, so it's the frontal lobe, often is multitasking, and then kind of being able to do things like mental math. So you're actually doing things in your head while your stuff is ongoing at one time, or being able to remember that after I type this paper, I'm going to print it out and turn it into the teacher. Sometimes we're just focusing on this task that's done, now what's next. So executive function is kind of coordinating all of those things into one cohesive experience instead of having to be reminded again and again, you're working on these 3 things, or this task happens after that task happens after that task. So it's kind of the higher level coordination of all of those things at once.
Okay, terrific. That's all I'm seeing coming in right now. Alicia, you see anything else?
I do not.
Okay. Well, anybody who is listening, now would be the time to submit a question. We'll just give it another minute here.
Sure. And I'm gonna, I'll zip back to, sorry for the whiplash.
It's okay.
Here, yeah, I'm happy to answer questions via email if
perfect.
questions come up later.
Wonderful, thank you. All right, Kristen. Well, I don't see anything else come up on my screen for questions. So we just want to, John and I, and on behalf of the foundation, want to say thank you for your time tonight and your expertise. This was wonderful. As John mentioned, we get a lot of questions on this. So we.
Let me also just say that for anybody who's listening, we're going to do a much more comprehensive and extended series of virtual meetups when we get closer to the school year during August, back to school month. So
yeah,
you'll see this again.
Yes.
Great.
Awesome. All right.
Cool.
Well, thank you, everybody. We appreciate your time this evening. Have a good night. And I just want to say really quick before we end, normally I say what's coming up next week. Well, next week is kind of a longer holiday weekend for people with the 4th of July. So we are actually not going to be having a VMU next Thursday, but we'll see you back here on July 8th, I believe it is. And we're going to be doing an Ask the Pharmacist type of Q&A. And you can ask about medications and all of that good stuff. So thank you again, and we'll see you guys in just a couple weeks.
All right.
All right.
Good night, everybody.
Good night.
Thank you. Good night.
Thank you very much. Bye.
Bye-bye.